Right. Good morning, everybody. Good
Good
morning.
morning.
Good morning. I want to thank you all for joining us, and I want to kind of call us to order. Before we actually get started, I want to turn it over to my colleague, Michelle Williams, who is, this is Melissa Riva from the Center for Healthcare Research and Transformation. I'm going to turn it over now to my colleague, Michelle Williams, who's going to give you some information about the webinar logistics and how to ask questions and things like that. So take it away.
Hi, good morning, everyone. I'm Michelle Williams from the Center for Healthcare Research and Transformation. Thank you for joining us this morning. Just some housekeeping issues. If you're hearing audio but not seeing video right now, if you're in Google Chrome, for example, to the top right of your address bar, there should be a little window that tells you to allow your video plugin. Also, during the presentations, at the end of them, both of them, you'll have a chance to ask questions because there are over 50 participants. Everyone's audio is muted right now. So if you want to ask questions, you can feel free to type them on the right side of the screen. You will see a chat box. You can type your questions during the presentations. At the end of the presentations, feel free, just as they come to you, you can type your questions in. And Marianne, who will speak shortly, she will be moderating and putting your questions out, and then the presenters and the relevant people will take care of them. And with that, without any further ado, if you have any questions further about viewing, and if you're not hearing, please type that also in the chat box. We have a technical staff here who can help you with that. Without further ado, I'll turn it over to Paul from the Michigan Health Endowment Fund.
Thanks, Michelle. I am Paul Hillegans with the Michigan Health Fund, and I want to thank you for joining us today. This is our very first learning webinar, and we're really pleased to have you all participate. I also want to thank Senior Fellow Janet Olszewski and Fellow John Sloan for planning today's learning opportunity. Our Health Fund's teams is very committed to listening and supporting our partners to achieve their goals. And today's webinar is a direct result of listening. Recently, at our 2016 Behavioral Health convening, grantees suggested to us that learning more about how to look at the cost impact of programs would be helpful. Consequently, we have engaged the services of the Center for Healthcare Transformation and Research to develop this webinar, and we decided that grantees from other cohorts might be interested as well. And so we've invited all of our partners to participate. We look forward to conducting future learning opportunities for our grantees, and you are the first group to participate, so that we hope you will find today's program to be helpful, but also we're looking forward to your feedback on both the process for preparing for this webinar and the content for the session today. Michelle is now has talked about the logistics. So Michelle, I think I'm supposed to turn it back to you or to Marianne, but I do want to thank the entire CHART team for preparing this webinar this morning, and we look forward to participating.
Great. Thank you, Paul. And this is Marianne Udow-Phillips, and I want to add my welcome to everyone, and thank you all for joining us. We're delighted to have so many grantees of the Health Endowment Fund joining us this morning, what we hope will be an enormously helpful seminar for you and sort of the start of a dialogue to help you be more successful in the work that you're doing. I'm going to briefly introduce our team this morning and tell you for a minute what it is, how we're going to approach the webinar, a little bit in addition to what Michelle had to say, and then we'll launch into the presentation. So as I said, I'm Marianne Udow-Phillips. I am the director of the Center for Healthcare Research and Transformation. We are here hosted by the University of Michigan, and it is our goal to help improve access to care, improve cost effectiveness of care and population health, and so we're really happy to be able to participate in the work of the Health Endowment Fund in that context. We have two main presenters today, Paula Lance, who is the Associate Dean for Academic Affairs and Professor at the University of Michigan Ford School of Public Policy. Dr. Lance has a broad background in health and public health, teaches evaluation. I can't even begin to do her resume justice. She's a social demographer. We are just so thrilled that she has agreed to help us with this presentation this morning. There's no one more knowledgeable than Paula about both health policy and research and evaluation. So we're delighted she's here. And then she is going to go through, sort of give you the basic understanding of how you can measure cost impact. I'll share with you in a moment sort of that continuum. She's going to go through the continuum of evaluation strategies and give you some framework and some ways to think about how to gather data, how to talk about cost and measure your impact. As Michelle said, we'll then take a brief break to give you an opportunity to ask her questions on those methodologies. And then Melissa Riba, my colleague here at CHART, who is our Director for Research and Evaluation, will present some examples actually drawn from some of the projects that have been funded by the Health Endowment Fund. Melissa herself has a deep background in evaluation and research as well, and is going to help make what Paula has to say a little bit more applicable and concrete for those of you involved in the projects. After Melissa does her part of the presentation, we will also have an opportunity for questions for both Paula and for Melissa. So our goal is to pack a lot in the next till 11 o'clock, and that's where we're going. So I wanted to start with just a little bit of framing about why you would even want to measure the cost impact of the work that you do. And, you know, we're delighted that so many of you really asked for this kind of seminar for the Health Endowment Fund, because I think you see the importance both of evaluation more generally and the role that cost plays more specifically. You are all engaged in projects that I know you're passionate about and that you believe will make a significant difference in those you are serving. And yet you also know that the work and the funding that you're getting from foundations, from the endowment fund, is really intended to help you find that project, show its impact, and make the case. But foundations and other funders like foundations are short-term funders. And you are all, I believe, trying to establish initiatives and programs that will be sustainable for the long term. In order for projects to be sustainable, those who would be the likely payers for those services need to understand the impact that you're making. Impact, of course, can be measured quite broadly. Paul is going to talk a little bit about that. Impact is not limited, of course, to cost. You know, you're clearly focused very much on the impact on human lives. That's enormously important. But generally, payers are also going to want to understand the impact on cost. Developing a measure of cost is complex. Paul is going to go into that in some detail. And it starts with understanding who you are doing the measure for. Who are the payers? Are the payers state government, who looks at cost in a particular way? Are the payers health plans, who look at cost in a different way? So you're going to want to understand at the outset what cost you're trying to measure and who the stakeholders are who are going to be interested in that cost and how they will consider cost. Funders have a lot of different ways of looking at impact. And so starting with that foundation of understanding who you're measuring cost to and for, and how they are likely to measure cost is going to be quite important. And we can talk about that more as we go, and certainly more in the questions. Our goals for the seminar today are to provide, as I said, that overview of how you demonstrate cost impact. And you can see on this slide the kinds of pathways that we can take to measuring cost, all the way from understanding what the literature says, what other researchers have found with regard to programs or initiatives like yours, to doing full-blown cost-benefit analysis. And as I say, Paul is going to talk about the differences between those types of measures and help you understand the importance of those analyses as you discuss them with stakeholders. We do hope to engage with you in a discussion of where your program is at with regard to particularly demonstrating cost effectiveness. And quite a lot of what we talk about today will focus on that issue of cost effectiveness. And Paul is going to tell you why we think that is the area to really focus on. But we wanted you to also understand how that fits in this whole continuum of measuring cost impact. So I'm going to turn it over to Paula to launch, and as I say, she's going to go through a presentation to understand that pathway. We'll then take a break for questions, and then Melissa will give you examples.
Great. Thank you, Marianne. Good morning, everyone. I'm really delighted to be here with you this morning. I'm sure for many of you, spending a couple hours on a gloomy morning here in Southeast Michigan, for us anyway, it might not be your most favorite thing to do, but we're really glad to be here with you and talk about some of these really important, yet also technical and rather complex issues. What I am going to be doing with you this morning is really, at a fairly high level, I will say, talk to you about this family of methods in terms of economic analysis of programs and interventions that all have the same general purpose, but they are different. So we're going to start and talk about cost-benefit analysis and then move into cost-effectiveness and cost-utility analysis. And for all three of these approaches, the overall goal is the same, and it's really to help policymakers, funders, and other stakeholders understand what might be the most efficient means of achieving desired objectives, again, with different kinds of interventions, programs, policies, and services. And so these methods are all designed to provide information regarding the value, really looking at what are the resources that need to be expended relative to what we're getting back in return. So what's the value achieved by these interventions? And the premise here is that there really is resource scarcity. We're not in a situation where there's just unlimited funds to do everything we want. Policymakers and funders have to make choices, and they are often choosing among options. And this kind of information can help policymakers, funders, et cetera, you and your own programs decide what is going to give us the most value. So let's start with CBA, or cost-benefit analysis. And again, the overall purpose of this approach, this economic approach, is to determine, among alternatives, what is going to produce the greatest net benefit. And here, the important thing about cost-benefit analysis to remember is that in this approach, both costs and benefits are measured in monetary units. And because everything here is measured in terms of money, and again, including the outcomes, cost-benefit analysis is actually extremely technical and challenging in a lot of ways. So again, both net benefits, both costs and benefits are measured in monetary units. So let's start with net benefit. That's comparing how much did we get out of an intervention in terms of economics compared to how much money went into it. Let me just start with a simple hypothetical example. Let's say that we did an intervention, it served 100 people, and we determined that the benefits of that intervention actually saved our agency, our program, whatever, $180,000. And it cost us $120,000 to run the program. So very simply, this is a net benefit of $60,000. Again, we saved $180,000. It cost us $120,000 to run it. So we have a net benefit of $60,000. And since we had 100 people in the program had costs of $1,200 per person, benefits of $1,800 per person. And again, all the benefits here are monetized, and that's the really technical and challenging part of it. which I'm not going to get into in this hypothetical kind of simple example. But here, I hope you can see then you can compute a couple of things if you have that knowledge. Again, how much did it cost overall and per beneficiary? And then how much was saved, if anything. Oftentimes nothing is saved. We need to be really clear about that. But how much was saved in this situation per beneficiary? And here we could compute a cost-benefit ratio, and that would be the $1,200 dollar cost per person compared to the $1,800 benefits per person. That's a cost-benefit ratio of 0.667. That, in turn, means the program costs 2/3 of what it generated in benefits. And it's kind of at this level that you are going to be communicating to funders and policymakers. Again, very technical. Lots of time and effort would go into sort of this bottom line ratio. You also could look at it in terms of a benefit cost ratio. And again, here we just flip the numbers, but here's another communication point. For every $1 that was spent in this particular scenario, the program generated 50 cents in benefits. So again, a couple different ways to communicate that bottom line measure to policymakers. Let's look at a particular example here. Head Start is a program that's been around for a long time, and there have been a number of cost-benefit analysis of Head Start, all of which have shown that the program does indeed save money, more money than it costs. And in this case, if you look in the bottom left-hand corner of this table, you'll see that what's monetized in terms of benefits in this analysis is looking at children who go through Head Start over their lives. They have better labor market earnings than children who don't, similar children who don't. They have lower costs within the criminal justice system. They have lower health care costs. So if we look at all of those benefits and then we monetize them, we can see that Head Start, again, produces more benefits than it costs. It has a benefit to cost ratio of $2.63, and that's great. There also, though, have been some newer and different approaches to early childhood education, and there's been economic analyses of those as well. And they have shown, similar to Head Start, that the benefits, again, in terms of dollars, are great. And relative to the cost, some of these new kinds of programs compared to Head Start are actually doing a better job in terms of saving the public sector money. So again, you could look at these individually, but also in a comparison, you see that actually a government might get more value from some of these newer approaches to early childhood education than traditional Head Start. Okay, let me do another example. I think it's where the examples are going to make some of this, the concepts come more alive for all of you. So there's an intervention done within the Denver Health system. Denver Health is a large public healthcare system with a strong public health component, obviously in Denver, Colorado. They implemented an intervention that involved community health workers doing outreach to low-income uninsured men in the community. And this particular evaluation, I'm just giving you the bottom line results of the evaluation. They found actually that the intervention increased the costs of primary and specialty care visits for the men receiving the intervention, but it also in turn reduced costs, more expensive healthcare costs in the areas of urgent care and inpatient and outpatient behavioral health care. And overall, they found that for the Denver Health system, this intervention actually reduced, should have a minus sign before this number here, this intervention reduced monthly uncompensated care costs for the Denver Health system by over $14,000. They also kept track in this intervention of how much it cost to implement the intervention. It cost about $6,300 a month to to run the intervention. So overall, their cost-benefit analysis showed that they saved Denver Health System $2.28, and yes, sometimes these analyses go right down to the penny, $2.28 for every dollar spent on this intervention. And that adds up to an annual savings for this health system of about $96,000. Whoops. Okay. All right, so that's cost-benefit analysis. And again, in cost-benefit analysis, everything is monetized. The costs, obviously, but also the benefits. Benefits are thought about in terms of money. Cost-effectiveness analysis is a bit different. Cost-effectiveness analysis, the purpose here is to determine which of alternative interventions designed to achieve the same objective could either produce more of the desired outcome for a given level of expenditure or cost less to achieve a given level of outcome. And again, I know that's a little confusing, and let's just go to more detail and then some examples. So in cost effectiveness analysis, again, costs, obviously the costs of running an intervention are measured in monetary units. But here in this case, effectiveness is measured in a non-monetary unit. So here we're looking at, well, what does it cost to achieve some kind of unit of an outcome? And these are typically the final outcomes that are being looked at in an evaluation. So it could be years of life saved, years of education attained, incarceration rates, et cetera. It could be then also some more intermediate outcomes, such as behavioral changes that are expected to improve outcomes down the road. Like we know interventions that get at behavioral changes in physical activity or smoking cessation could eventually lead to health outcomes and reduce healthcare costs. In a cost effectiveness analysis, you might be looking at those more intermediate outcomes. Say a disease management intervention that's looking at people and looking at their hemoglobin A1C, if they're people with diabetes, you could look at, well, what are the costs of the intervention for having people have better control over their hemoglobin A1C. So again, here it really depends on what you're looking at in the timeline, but you can be looking at final outcomes or more immediate outcomes. And then the cost effectiveness ratio is the monetary units. How much does it cost per unit of the desired outcome? And I, in a very non-technical way, always like to refer to this as, quote, bang for the buck analysis. It's really trying to help you understand how much are you getting for every dollar that you spend on this intervention. Here's an example, maybe not relevant to the kinds of things you're doing, but it's a nice example because it actually shows comparatively what the cost effectiveness is for the same outcome across a number of different interventions. So here is a study that was done regarding a variety of different HIV or AIDS prevention activities in Chad, Africa, which has a really high rate of HIV. At the time of this work, 9% of all adults in this country were HIV positive. So cost effectiveness analyses looked at what would be the cost per HIV infection averted. So again, in this case, the outcome, it's not translated into money. The outcome here is for these different interventions, an infection of HIV averted again. So here you see that screening blood donors has a pretty low cost. It costs less than $100 to avert a case of HIV transmission from screening blood donors. Some more expensive interventions, but still all fairly reasonable, antiretroviral therapy for pregnant women, voluntary counseling and testing. This analysis suggested that both of those cost $1,000 per case of HIV averted again. So you have the dollar amounts here. We'll talk in a minute about, well, how do you make sense of that, and when are you able to call something cost effective or not. Here's another quick example. So there's a vaccine for Lyme disease now, and policymakers have questions about, should we suggest that everyone get this vaccine, and what would that cost, and what would we gain from it, versus should it only be recommended for people who live in areas where the incidence of Lyme disease is pretty high. And so this analysis concluded that if everyone got the vaccine, it would cost $1,600,000 per case of Lyme disease averted. And I don't know about you, but that seems like a lot of money to me, $1.6 million to avert a case of Lyme disease, versus if the vaccine is recommended and promoted in areas where the incidence of Lyme disease is over 1% of the population per year, then it costs less than $10,000 per case of Lyme disease averted. So the conclusion of this study is that community vaccination should only be implemented in areas where Lyme disease is endemic. And again, that's based on this bang for the buck analysis, the cost per case of Lyme disease averted. Now, you might imagine that people who have to make challenging resource allocation decisions are not usually going to be comparing interventions that have the same outcome. You might have to decide between, do we want to promote Lyme disease vaccination versus obesity prevention versus dealing with the opioid epidemic versus lots of other things. And if we're really comparing, if we're doing cost effectiveness analysis where everything has a different effectiveness metric at the end, that becomes difficult. So this last class of economic analyses, cost utility analyses, is really trying to get at that problem. If we're, first of all, again, not going to monetize everything as is done in cost-benefit analysis, because that turns out to be pretty hard and challenging. And then in cost-effectiveness analysis, if we have these different outcomes, again, how can we compare across them? So cost-utility analyses tries to do that by comparing kind of general metrics getting at utility or sort of usefulness across different kinds of interventions. Here, again, costs obviously are measured in monetary units, but utility is measured in a non-monetary unit in some kind of metric that is comparable across different kinds and classes of interventions. A common metric is life years saved. So comparing the costs per the utility of life years saved across a number of different interventions. Then you can adjust those life years saved for quality of life. So then we get into something some of you might have heard about before, QALYs, or quality adjusted life years saved, disability adjusted life years saved. There's other approaches with this. This all, again, gets extremely technical. You can use things called the health utility index. But again, the purpose here is try to have a comparable measure across different kinds of interventions that are getting at different problems and issues, so that you can compare what you're getting out of them in making decisions in terms of allocating costs. So there was, here's a quick example, which is, this is both a cost effectiveness and a cost utility analysis looking at exercise. But in this particular modeling, it was a simulation model based on a number of different studies that tried to look at, well, what are the health benefits of jogging? And this analysis considered not only the costs of promoting the intervention, but also the cost of exercise. I don't know how many of you are runners. I happen to be a runner, and running shoes are expensive. I actually have had to invest in orthotics because running's hard on your feet. So I have expensive orthotics. I luckily haven't had any injuries, but a lot of my running friends have had to have knee surgery and other kinds of things, and that results in some healthcare use. So if we are going to be thinking about the cost utility of promoting this kind of exercise, we need to think about all these costs. So it does turn out that jogging is very good for cardiovascular health. So running does, and this particular simulation exercise was focusing on men, but the results suggest that out of 1,000 men who are running, there would be 78.1 fewer cases of coronary heart disease. And that produces an increase of quality adjusted life years for these men. Again, not going to get into the weeds on how they determine that. But it also was determined that jogging costs $11,300 and some dollars per quality adjusted life year saved. So at the end of the day, and because that number is positive rather than negative, it turns out, this surprised me, I wasn't happy when I read this study, but jogging is not cost saving actually to the healthcare system. Which is probably good to know, but again, sort of disappointing. And I have to say, a lot of times when you do get into this economic analysis, the results are disappointing. It does turn out that a lot of interventions that do provide benefits for people don't end up overall saving money. If you take all the costs and have kind of a wide perspective in terms of the cost, they're not going to turn out to be cost saving. But that's okay. It's still, we might want to do it. If an easy intervention like jogging, does improve people's quality of life, and it costs us a bit of money to do that, we might still want to do that, right? We're not going to limit ourselves to only thinking about things that save money. I'm not going to go through this, but if you have time and you want to look at it, here's actually the cost utility results from the Diabetes Prevention Program. Research that shows, again, impact on the cost per quality adjusted life year. And it turns out the Diabetes Prevention Program isn't quite cost savings, but it still produces quite a lot of benefit for people who get that intervention. So again, let's just take a moment to review here kind of what are the bottom line measures in cost benefit, cost effectiveness, and cost utility analysis. Cost-benefit analysis, when you're talking about that, again, everything is monetized. So cost-benefit analysis, the preferred measure is the net benefit in terms of money relative to the cost. Cost-effectiveness analysis, the bottom line measure here is a cost-effectiveness ratio in which costs are divided by some kind of unit of effectiveness, and really focusing on what are the intentions of the intervention, either the end outcome goals of the intervention or something more intermediate. And then cost utility analysis, that is the brother or sister or close relative of cost effectiveness analysis. And here it's like cost effectiveness analysis, but you're trying to get an end result that's going to be comparable across a number of different interventions, some measure of utility, some global measure of utility. All right, and let me just reinforce this important point. Cost effectiveness analysis and cost saving analysis are two different things. And that means if you want to call an intervention cost effective, that's different than calling it cost saving. And there's a lot of confusion, understandably, and a lot of misuse of the term. But I would urge you to make sure whatever kind of claims you want to make about your intervention, make sure you are not calling something cost saving when perhaps it's not. And if you want to make a claim of cost effectiveness, that's great, and you need to back it up, but actually it doesn't necessarily mean that it's cost saving, right? So cost effective, again, doesn't mean that money is saved. It generally means that someone thinks the result is worth the investment that you're putting into it, or it provides enough value for the cost. And that, my friends, turns out to be a very subjective sort of thing. So, I mean, one of you on the phone might think it's cost effective to vaccinate everyone for Lyme disease. Having it cost over, Lyme disease is a terrible thing to have. So if we need to pay $1.6 million to prevent someone from having a debilitating illness, oftentimes for the rest of someone's life, that might seem cost effective to someone versus someone else might think that seems like a lot of money to spend. We might want to focus our scarce resources in another manner. Now, this is another technical issue I want to get into just a little bit, so you know that in a lot of these kinds of analyses, there's a lot of uncertainty. Analysts and researchers talk about uncertainty as the value of a component or a variable in an economic analysis that might influence the conclusion of it, and that's really unfortunate because we're really uncertain about what that value is. How am I doing on time? Fine, okay. So here's an example for you. So there is a cost-benefit analysis looking at, is it a good idea for work sites, many of which do this, obviously, to promote influenza vaccine among their working population. This analysis, it says here it used a societal perspective. That means it took a very, very broad look at what are the benefits for immunizing our workforce beyond what they might mean to people not missing work because they're sick. What are the benefits provided to families, keeping kids in school, et cetera, et cetera. So the results of this analysis showed that on average, there would be $13.66. Again, a lot of these analyses go down to the penny, but the mean savings would be $13.66 per person vaccinated. But there were a lot of things in this modeling that the researchers didn't really know. What exactly would be the work absentee rate? What are the hourly wages of the people getting the vaccine? That's going to vary within work sites and across work sites. Also, what matters for those of you in public health and understand about vaccines, the influenza vaccine is in some years more effective than other years because of the not pure science of matching the vaccine to whatever the circulating strains of influenza are going to be in a given year. So what this analysis did was run this model, this analyses in a bunch of different ways, basically varying the assumptions in the model and these different things that are somewhat uncertain to see if it mattered. And it did. In some situations, it turns out that in some situations, if you have a different set of hourly wages, if the influenza vaccine isn't as good in one year as another, it might mean that this is not a cost-saving intervention. The results are sensitive to all of these factors going into them. Now, in most of the analyses that they did, they found that vaccination was cost-saving, but it wasn't always the case. The main point here is that this kind of analysis, cost-benefit analysis, where everything is translated into dollars, it's really hard to do. It's really hard to translate some of these things into dollars, and you have to make a lot of assumptions, and your results can sometimes be really sensitive to those assumptions you're making. I have another example here. I'll just leave that to you to look at if you want to underscore that point, that again, sensitivity analyses is really, really important for this kind of endeavor. No one really does any of this kind of analyses without doing some level of sensitivity analysis because there's always some uncertainty. All right, so, and another important thing to think about is really there are a lot of limits of doing this kind of cost analysis. across all the kinds, cost effectiveness, cost benefit, and cost utility analysis. And I have here on my slide, caveat emptor, buyer beware. Again, because these are very technical analyses, they depend a lot about assumptions going into them. There can be a lot of technical issues with them. And if this isn't done right or doesn't involve a lot of sensitivity analyses, you really often cannot even be sure of the results coming out of this. I'm just being really honest with you. There are a lot of, I'll talk more about this on another slide. There are a lot of people who just have serious mistrust, especially of cost-benefit analyses. It's really hard to take every bit of benefit from an intervention and try to translate that into dollars. So there are a lot of technical difficulties and problems that go into this kind of endeavor. I also mentioned that, because you have uncertainty about many of the key elements, that leads to this heavy reliance on sensitivity analyses, and then often at the end of the day, the sensitivity analyses produce such a range in results that you're not really even sure what you have. It's hard to make conclusions. Also, a lot of times this kind of analysis, it's really hard at allowing us to look at, what it says here on the slide, kind of in technical terms, distributional concerns or inequities. But what we mean by that is that a lot of times you have interventions and they're aimed at populations that are vulnerable in a lot of ways, and populations that also have a lot of heterogeneity or differences within them. So it might be that you have an intervention and it's great at reaching parts of your population, but not other parts. Maybe it's great at reaching people at higher income levels, but not so great at people at lower income levels. You might have an intervention that's great at reaching some racial and ethnic groups, but not other racial and ethnic groups. You might have an intervention that has different levels of effectiveness across different subpopulations within your clientele or your service population. And these kinds of economic analyses aren't really great at getting at those kind of concerns about differential impact and equity. And it actually might be that an intervention produces more benefit in certain populations than others. It might be that the intervention is more, quote, cost effective or cost saving in some populations rather than others. And it's really hard to do that unless you have a giant sample size and, again, are going to be spending a lot in time in terms of technical effort to get at that. And then also, I think I know in my world, in the healthcare world, and in the public health world as well, a lot of times people present the results of these economic analyses as sort of like, here, this is the bottom line, this is the money, as though they are just, here's the facts, sir or ma'am, and interpret them and take them and sort of value free, because it's just it's bottom line. Here's how much it costs to achieve this outcome. Here's the overall cost savings. But there are a lot of hidden values in this kind of analyses, and again, how it's even approached in the first place. So we just need to recognize that. There are concerns about the use and sort of misuse of this analysis. Some people think it's widely misused. There are a lot of numbers that are put in front of policymakers. Hey, this program is going to save you, $86,000. Well, how do you get to that? And a lot of times there's fixed costs. I know I've seen a lot of studies lately that suggest that, averting one person from going to jail, and an incarceration is expensive, would save the government X amount of money. Well, there's fixed costs to running a jail, so no, it's not that easy to get to that bottom line. So while we think there are many positive impacts of using these kinds of economic analyses for decision making, decision assisting, just more information, they also can be misused, not intentionally sometimes, but also I've seen this kind of analysis misused, I would say, somewhat intentionally as well, and we just need to be aware of that. All right, in my limited time left, I want to give you an example of a cost effectiveness analysis that I did in my career. And it doesn't really matter what the intervention is, but so much as I just want to suggest to you an approach you can use generally in terms of methods. In this particular study, the intervention was a physician reminder letter combined with telephone counseling from an RN regarding barriers for women getting their screening mammograms and Pap tests. So the setting here was a multi-site managed care plan that had community health center funding. And the population was low-income women who, in looking at their administrative data, we identified women who were not up to date on their mammograms or Pap tests. And so again, they got the intervention. And our evaluation design here, we actually used a randomized controlled trial that included a process evaluation and also a cost effectiveness analysis. So here is a graphic depiction of our evaluation design. So we had two groups. The R stands for randomization. So one group of 337 women was randomized to get this intervention, and another group was then randomized to have usual care. And then you see the X after the O. The X is the intervention. And in this case, it was a delayed intervention. We went ahead and gave the intervention to the women who were originally assigned to be in the control group after we found out the intervention was effective. So they got the intervention later as well. Our outcome here, we were looking at cancer screening. So that's our unit of effectiveness. Did a woman get the cancer screening test or tests that she needed in the 6 months after the intervention? And we did find that women in the intervention group were actually 4 times as likely to get all their needed cancer screening tests in the 6-month follow-up period after the intervention than the women in the control group. We also, in this, we were happy to know the intervention was effective. We also then wanted to be able to tell policymakers, well, what is this going to mean for you in terms of resources, both human and cost-wise? So we had some, again, both process evaluation and economic evaluation questions. So we wanted to know, okay, was the intervention implemented as it was intended? And what did it take in terms of human and other resources to implement this intervention? And how much did it cost? And then at the end, what was the cost effectiveness of the intervention? And here we combined our impact and process information. And because we had a control group, we could say what was the cost per screening test received in this population above expected. And we used the amount of screening. There were some women in the control group who got screening tests during the 6 months of our intervention, and we used that as our measure of what would have been expected without the intervention. So in terms of looking at costs, there's nothing really secret or special or technical about this. We just spent ridiculous amounts of time and effort to make sure we were capturing every bit of cost associated with this intervention. What were the telephone costs, letterhead, envelopes, and stamp costs, data, asking people from medical records for data runs costs, gas. We sent these letters through the mail, and women's physicians signed them, and so someone had to drive around to a number of different physician offices. 110 different physicians signed these letters. So what did it cost to get to them and get them to sign the letters? So we looked at all the costs, and a lot of the costs here were labor costs. And so we actually asked everyone involved with this intervention to, through well-established time and effort, sort of operations research kinds of time and effort studies, to log their time. And then we translated that into effort based on their salary. So we actually have published an article about this. So if you want more detail on some of the methods for this, I'm happy to talk to anyone, or you can look at the article that we published about this. But again, we really wanted to look at, how much time were people spending on different parts of this, and then how did that translate into costs in terms of labor and other costs. So we found that staff spent 35 minutes actually per letter that we sent out as part of this intervention. And a lot of time was spent, it's hard to get people on the telephone. It was hard then, it's even harder now. A lot of people don't even have landlines anymore. So it took a lot of time and effort to get women on the phone. How much time did the phone calls take? Again, we have some great process information that helps us think about other ways in which we might be able to implement this intervention in a more efficient way as well. So the bottom line, again, this is a cost effectiveness analysis. So we were looking at, well, what were the costs per different results? So this intervention cost $15.63 per woman who received it. But in terms of effectiveness, again, some women were going to get their screening tests without the intervention. And so we found that it cost $31.60 per screening test received, above what was expected, the 52 women in the control group who got screening tests. And then we also knew that because we were doing this in the context of a research study, some of the time and effort of staff was involved with doing research on this, which wouldn't be done in a normal sort of setting. So removing the research costs, bottom line, this cost about $29 per screening test above expected when the research costs were removed. And then we did some sensitivity analyses around this and found that we could, through some efficiencies, probably get the cost down even more. If we used support staff instead of an RN for doing the calls, if we use volunteers for doing the calls, we reduce labor costs, and that then obviously would make the cost lower, and it would make it look even more cost effective. So to summarize, and really focusing on cost effectiveness here, what you need to know to do this kind of analysis is that you really need to know what is the impact of your intervention. What is the bang of it? What is that unit of effectiveness? And that needs to come from some kind of what in evaluation terms we would call a summative evaluation, an impact or an outcome evaluation. And then you also need to have a sense of what are the costs of that intervention. And here you really need to do that. You need to do that in the context of a process evaluation that gathers information both on some aspects of what it takes to implement your intervention, and then what are the costs associated with those different aspects of intervention implementation. And then you put the two together, cost effectiveness analysis, again, cost per unit of effectiveness or bang for the buck, puts together the impacts and the cost. Now again, labeling an intervention as cost effective is subjective. There are some values in it. It's basically saying that outcome we're getting is worth the cost. I personally think spending $29 to have a woman in a low-income community health center context to get a cancer screening test, I want to label that cost-effective. Right? It didn't save money, but it's again spending less than $30 per woman to get them a cancer screening test that we know that's been proven through other research to be a good thing. So cost-effective means that somebody thinks the impact is worth the cost, and that's generally you're going to have to be convincing then the policymakers, the funders, the people who allocate resources about that that it is cost-effective. No technical or magic ways to do that, but you definitely need good data to even enter that sort of conversation.
Thank you, Paula. So we're going to take a break now for questions, but I want to pick up on a couple of points before we go to the questions that Paula raised and also lay some groundwork for what Melissa's going to talk about next. Because, what Paula just went through for you was to give you that real foundation of understanding these different methodologies for evaluating cost impact and to understand all that really goes into them. Our goal was not to turn you into researchers or evaluators yourselves, and we know that many of you come from very small programs, and you don't have the resources to do the kinds of things that researchers would do to evaluate the impact of your programs. But what we wanted you to understand so that you could talk effectively about your programs to decision makers, policymakers, is what they'll be looking at when they're asking you questions about the cost impact of your programs. Quite honestly, in these days, if we're talking about health plans who might, be considering developing a new code to pay for care management services for programs that you're interviewing or that programs you are designing, or if we're talking about state policymakers who you're going to ask to fund certain types of programs, many of those policymakers have been inundated with vendors who have come to them over the years and said, we can promise you a 5-to-1 return on investment. And so many of those policymakers have gotten wiser to ask questions about, well, what goes into that 5-to-1 return on investment? And there's usually, quite honestly, a lot of smoke and mirrors in those numbers. And so they tend to ask more questions these days about cost impact and how you calculated the cost impact. We also know, and in Paula's example, if we're designing programs from a research standpoint and really trying to show as best we can what the impact is on in a range of things, including cost, the gold standard is a randomized controlled trial where you have two groups, one who gets the intervention and one who doesn't get the intervention, and they're similar types of groups, and you can really determine the impact of the intervention itself. We know that most of you are not going to be in that situation. You're not researchers, you're not designing randomized controlled trials, you're not setting up these comparison groups. But you are still going to be asked the question by potential funders about cost impact. And so what we really wanted to lay out here was to at least get you to the point where you can begin to, when you set up your program design, begin to gather the data that could help others, evaluators, or policymakers even answer the questions about cost impact. So you heard the kinds of things that Paula talked about that she and her colleagues gathered when they were looking at what the impact of the program for breast cancer screening was. And so even just having you, as you start your interventions, capturing that cost information and identifying where you believe the cost savings or cost value, if we're talking about cost effectiveness, could come from, is a very important foundation. So we just hope that today we can help you understand what you might want to gather in terms of information. Almost all foundations these days are asking projects they fund to have some evaluation component and to work with evaluators, and they are going to want that information that will feed into the kinds of things that Paula is talking about. So setting up your programs to capture that information at the outset, to know what are the impacts you're going for, and tracking some of that cost will be very useful for any evaluator that's working with you to show the impact of your program. So that really is the foundation of what we're trying to get across at the moment to help you understand how evaluators think the information that they're going to gather, what case they're going to try to make to show that the programs you're engaged in have value. So we're hoping that that came through in what Paula had to share. We do have a question from the participants that is a pretty technical question, actually. We must have an evaluator on the phone. This question is, and to Paula, how would you suggest that we put controls into regression-type analysis to account for the inequities in participants and patients? Paula, if you want to share your thoughts on that, that would be great.
Sure. I was actually just typing in a response to that in the chat box.
But we'll share it with everyone.
As well. It's a pretty technical question. I think here what you'd want to do, if you're running regressions, if you have enough data and in the right format to actually run some regression analysis, probably the first thing you're going to want to do is see if your intervention effectiveness is working different in different subpopulations. And in a regression format, the way you're going to want to do that is you're going to have to put in some interaction terms that look at the interaction of effectiveness with the subpopulation variables that you care about. Maybe you're interested in a gender difference, or you're interested in differences across different racial and ethnic groups. If you're in a context where you have an intervention group and a control group, you would use interactions to do that. Otherwise, you might just run separate regressions for different subpopulations. Without knowing more about the context and the data, it's hard to say more about that.
Yeah, but if you, as the questioner, have more, want to go into a little more detail about your question, we'd be happy to arrange some follow-up responses to you. And again, any others of you that have either technical questions or more foundational questions, again, we're trying to lay that foundation for you, help you understand the kinds of things evaluators, researchers look at when they're looking at these questions, so that at least you can be gathering that information so it's ready for policymakers who are going to be asking these questions about cost impact. So at this point, I'm going to turn it over to Melissa, who is going to take what Paula shared with you and translate it a little bit into some of the specific projects that you that the endowment fund has actually funded, to give you examples about how some of those projects are in fact applying these analyses, determining cost impact.
Okay, great. All right, thank you, Marianne, and thank you, Paula, for that great foundational presentation. I will try to avoid talking about regression analyses. Been there, done that in grad school, thank you. But I also am happy to offline. But what I'm going to really focus on is, you know, as Marianne indicated and as we talked about in the agenda, just trying to really pull in some sort of real-world examples from current grantees of the Health Fund. We're working with the behavioral health proactive cohort, so I pulled some examples from there. Just as a little bit of background, as part of another body of work, I'm engaged with some colleagues of mine at Public Sector Consultants with the Health Fund conducting some cohort evaluations of the cohort, so I have a pretty good deal of familiarity with these grantees. But what I want to do is take us back to the path that we looked at the very beginning, and what we're really going to focus on are those first three steps that are highlighted in red, because what I want to do is talk about, you know, now that we've sort of talked about, here's the foundational pieces, here's sort of the, you know, best case examples of what to consider. I really want to dig into using these examples, ways that grantees and people running programs could actually think about how they could talk about, how they could communicate, how they can plan for cost effectiveness analysis and evaluation. And again, just to reiterate, the goal here is not to turn everyone on the phone into health economists and you're going to, you know, come away generating your own cost effectiveness analysis, but rather just to give you some familiarity get you hopefully comfortable talking about costs, because sometimes I think that's very hard in, with community programs. So, the first 3 steps, we're going to talk a little bit more in depth. I'm going to go through 3 examples and look at each of those steps related to either the literature and the evidence base, the evaluation process and impact, and then also formulate, and we do not do cost-effectiveness analysis for these grantees, but rather just formulate ways and considerations that this analysis could potentially turn into cost-effectiveness analyses. So that's kind of an overview of where we're going to go with this portion. So what I want to do is start with the first example. This is the Behavioral Health Home Replication Project, or we're going to call it BHH for short, going forward. This is a grantee, Network 180, which is in Kent County. It is the community mental health agency serving Kent County. And they are, as it says, behavioral health home replication. So they are essentially replicating, testing, enhancing a behavioral health home initiative or intervention. This is an expansion of a previous pilot that they had that they had started in 2012. And so just a little background, just in case some of you on the phone are not familiar with the health home concept. It's just this idea of trying to sort of defragment, I guess I would say, the healthcare system by creating what we'd call a medical home or a home for a client or a patient, so that they kind of have like a one-stop shop for getting their services, which the literature and evidence has found to be effective in providing better care, improving outcomes, and various other, outcomes of interest. And the idea being in this project that the care coordination, in this case, because it's behavioral health, is focusing on mental health providers within the community mental health system, but also with primary care and doing better coordination than, say, the usual model of care within CMH, which is traditionally case management, which is a little bit different. So that's kind of an overview of the project. When we look at that first step, okay, and we're kind of looking at this first step of the literature, and this is a really important step. Many of you, all of you, have done this in some way, shape, or form in your proposals to the Health Fund, because what you've done is you're asked to sort of talk about what is the evidence for what you're proposing to do. So you all, in one way or another, have provided some of that information. What I've done here is just sort of pull some of that information from the behavioral health home project. And so essentially one of the things you need to start with is you make the case for why should someone fund this? Why should this be a project that would be of interest? That's the case you make in the proposal. But also in terms of thinking about cost and going back to Mary Ann's comment about thinking about ways you're going to get into and measure costs. This is something that the earlier in your planning and your project you can do, the better you're going to be later on down the road when you try to really think about costs. Because again, you need to think about, so the examples here are kind of demonstrating the need, but it's also about what are, so there are gaps in care. So this is a program that's looking at expanding services to new populations beyond the original pilot, looking at care for younger populations as well as the elderly. So what is the overall impact of the gaps in that care in the mental health system for these individuals, these populations that maybe are underserved? And then what can you do to tie that, maybe thinking about it, to cost? So you might not find the perfect study. You might not have the information at hand that exactly says, oh, here's the cost impact of, addressing mental health needs for the 18 to 25-year-old population. But you can look in the literature and see where perhaps there are ways that you can look in the national literature or other work that's been done and look at ways to sort of extrapolate. So if you know that, untreated mental illness within the younger population, which also has a co-occurrence with maybe greater prevalence of chronic conditions, what is the cost impact of those kind of comorbidities, those co-occurring conditions? And you can kind of look at that and start to formulate ways to look at cost. And so that's kind of part of the way you do this. And a lot of this that I'm going to kind of hit on are things that I know, having worked very closely with a lot of the grantees that I know are on the phone, these are things that you think about and you do when you're formulating the proposal, when you're thinking about, how you're going to run your program. So, it might be different language and terminology, but you all do this, I think, in one way or another. And so, so let's move to the next slide, looking at the process and impact evaluation, because I think that's our next logical step here. Oops, there we go. Okay. And so, again, I want to underscore the importance of evaluation. And, part of it is because it's, I'm a little biased because evaluation is in my job title. And anyone who knows me knows I'm a self-professed evaluation geek. I love it. But the reason I love it is because it can really help programs demonstrate their impact and really kind of carry that through. So when you get to the point where you want to communicate with your funders, with policymakers, with your community about the good work you're doing, it gives you a really clear, systematic way to do that. And, evaluation is, in my mind, it's really just a fancy term for a plan. It's that you're planning the work. You're making the plan, you're doing the work. And so it's a way of thinking deliberately, systematically, and thoughtfully about what you're doing, how you're going to know that you're accomplishing what you set out to accomplish, and then what is your ultimate impact. So within this example, and what I've done here is to break out the different elements of an evaluation, process measures, interim outcomes, and the longer-term outcomes. So for the Behavioral Health Home Project, the BHH project, these are, and again, if you have worked with CHART on the behavioral health or healthy aging grantees and worked with us on that cohort evaluation, you're familiar with what we call the output table that we've attached to the quarterly reporting that the Health Fund has for you as grantees. And, so you're familiar with the table, but all that does is just ask you to document per quarter how many staff, how many trainings, whatever it is that you're working on, how many of something you have done based on your plan. It is a way to help track, is your project going as you planned, but also towards the end, it helps you to quantify how many of people did you serve? And then when you want to tie that into looking at cost effectiveness and talk about that, that gives you some inputs for that. And, it's really, and when I say being deliberate is really important, I can't underscore that enough because even though it seems kind of like a no-brainer, well, of course we're going to track that. You'd be surprised how sometimes that ends up being harder than you think because, you just want to make sure, for example, that everyone in your program's on the same page about how you're tracking things. An example that I would use is that in one of the reports that we looked at with the grantee, they reported a number. We asked about the number of trainings or sessions that they held, and they reported like 70.5. And so we were kind of puzzled by, what is that? Is that half a training that went awry somehow and, you didn't complete it? And so then in following up with them, they were tracking it differently. It wasn't per session. It was because the way they tracked their time was by hours. So what they were giving us was not the same unit that other groups were giving us. And so that was something, again, so even though it seems kind of self-explanatory, having that deliberate thinking is really important. And so that's kind of the everyday sorts of process measures. But then the interim pieces, outcomes are, these are going to be your shorter term outcomes. Improving mental health status here, decreasing substance use, decreasing anxiety, depression. Those are outcomes that you hope going to accomplish within the project. Typically within this project and other projects that are dealing with, for example, mental health or substance use, there's an intervention that's being delivered, and then there's some periodic assessments that are conducted within the CMH system, and there's a whole series of standardized tools that are used here, and I'm not going to go into that, but the idea being that there's points, and that's data as well. right? So even if it's the standard course of treatment and therapy and the process, that's something you want to, again, be deliberate and thoughtful about to make sure you're capturing it in some form somewhere. You know, if it is it all in some paper file somewhere, you'd be surprised how often things are still, you know, even though we're supposed to be the digital age, things are still sometimes collected in paper. Is it paper? Is it going into the EHR? Where in the EHR? How's that collected? How's it going to come out? And, you know, can you even get it out? You know, those are things that need to be thought about because, again, when you're thinking about these interim outcomes and how they're going to feed into talking about cost and being able to talk about impact, you want to have that available. So, and then ultimately here, we've got as the outcome, or one of the outcomes here, decreasing emergency department visits attributable to behavioral health. And I'm going to talk a little bit about, as we get into cost effectiveness, that's one that is a really, I don't know if I call it popular, but it's an outcome that shows up quite a bit in a lot of health delivery research, behavioral health, but also within, you know, elderly populations. The idea being that, you know, ED, the emergency department is the most expensive, least effective way of treating populations and conditions where they might otherwise be better treated within the primary care setting. And so this is an intervention, you know, looking at keeping people out of the ED, treating them within their usual care settings, their primary care physician, that relationship. And so, you know, so it ends up being something that's very popular to look at because, of course, if you can reduce that, that's great and everybody's interested in that. It's also probably one of the single most complex ways of trying to attract and deal with cost because the different data that, you know, it goes back to what Marianne was saying about how do you define cost? How are you, you know, is it just whatever, you know, is it what the hospital bills? Is it what the payer pays? How are you defining that? And also, to whom are you making the case? So if you're using claims data, so typical sources that we see are, you know, using claims data or using administrative data like EHRs to look at utilization and to try to look at cost. But again, the ultimate audience is going to have a different set of questions. So what a hospital or a health system might see as cost effective might be very different from what a payer might see as cost effective because, again, it depends on what, you know, how you're defining it and what you're doing. So it can be very complicated. But that said, you know, again, I think the ultimate, I don't want to, you know, be a downer and say don't look at ED utilization, but the piece that I want to emphasize is that, you know, again, it goes back to that being deliberate, being systematic, and being thoughtful about what you can and cannot do with the data you have available and being able to be clear about that. There's no perfect data source that is the gold nugget of being able to do these kinds of analyses. There's always going to be limitations, and I think being aware of those limitations and being clear, you know, again, going back to Marianne's point about, you know, depending on your audience, there could be a level of skepticism for, you know, within those audiences based on their exposure to other kinds of cost analyses that make great claims about savings or effectiveness. Okay, so so let's see. So you know, again, kind of building on this, I wanted to talk a little bit about the evidence that the previous behavioral health home had, because the other piece that you can do is even if you can't do a cost-effectiveness analysis in the sense of what, you know, Paula was laying out, there might be ways that you can communicate this based on maybe previous work you've done. With this behavioral health home, based on their pilot work, they did indicate and have some findings that showed that there was a total cost of about $1,500 less per patient per year compared to similar individuals that weren't in the behavioral health home. So that, and then they also found that the inpatient psychiatric admissions were about 40% less for people in this program, and about 50% lower ED utilization for the behavioral health reasons for the people in this intervention. So again, even if that's not you know, something that you can put into a formal cost-effectiveness analysis, that's information that at least, you know, you can kind of use and carry forward within your analysis to at least begin to have that conversation and talk about that. All right, let's see, how am I doing on time? Okay, we're good. All right. Okay. All right. So then I want to talk now about a second program, which is Safe Passages Mentoring Program. This is a little bit different, and I chose this. We chose this program because it's a little bit different. It's a different program for a couple different reasons, and that also speaks to different ways that you could look at cost effectiveness and cost impact of programs. So this is a program that is being run by D.A. Blodgett St. John's, this is also in Kent County in Grand Rapids, and it's a child welfare agency. So it's, you know, this is a little bit different because it's not a typical health care sort of program. But this agency deals with a lot of, it's an agency that deals with foster children, foster care system, adoption, provides emergency shelter and counseling for families that are in crisis. And so one of the things that's very interesting about this one, and I know that in conversations with grantees, we've had, you know, there's interest in, but I'm being funded by some, you know, an organization called the Michigan Health Endowment Fund, emphasis on health. But what happens when the impacts or the, you know, cost effectiveness or the cost impacts accrue maybe to other systems, and how do we talk about that? So this was an interesting example for that kind of conversation. But essentially, just in a nutshell, this is a program that is aimed at increasing the reunification of children with their biological parents. So these are kids that are either at really high risk of going into the foster care system, or are already in the foster care system because of parents that are in crisis, you know, mostly due to substance use disorders. And so so the interim intervention, so even though the longer-term outcomes are focused on family reunification of children with their biological parents, there's an interim outcome related to the substance use and the intervention and improving the effectiveness of parental functioning due to substance use. So let me move to the literature. There we go. All right. So again, this is one where, you know, you look at the literature, you look at kind of what is the need, what is the potential for cost impact on these pieces. The interesting thing here, you know, again, looking at the, you know, drawing conclusions in the literature, looking at, you know, what has been done before related to unmet needs and higher risk for health risks of kids in foster care. And so one of the pieces of evidence that was cited with this proposal with the grantee was that, for example, 50% of kids in the foster care system have chronic physical health problems. You know, they have a lot of unmet need. There's also a lot within the parents, a lot of substance use issues, prenatal substance use. And so looking at things like what is the accumulated cost of those kinds of you know, those issues, that unmet need. And so, you know, even though you're not saying here's what we think we're going to do, here's the impact we believe we're going to have on cost, you can make some conclusions by looking at what are the, you know, what does the evidence say, or what does the literature say about the potential for that unmet need. Now, again, you know, one of the things that's interesting here that's maybe a little bit different is that in many ways we're really talking about, you know, systemic costs, because we're not just talking about an intervention or a program that's just focused on the healthcare, but it's really looking at it across systems, you know, across the lifetime of people affected by these issues. You know, what are the cost impacts that occur because of the unmet need, and because, you know, when you know, basically when parents have a substance use disorder and a child is placed in foster care, what are the, the higher risks and the costs there. So, and this is one where I did have the privilege to actually have some communication with one of the grantees and ask for kind of their insights on their program and cost effectiveness. And, so some of the information that was shared with me in that communication was, kind of the thinking that they went through when they were trying to sort of figure out how do you talk about cost effectiveness, even though maybe, they haven't done this formal analysis. And so some of the pieces of information that were shared was that, for example, in Kent County, you can sort of you can look at the costs and say foster care costs about $22,000 per child annually. And so just by, just in the simplest form, if you were just to reduce the case, what he indicated was that, what we would say is if we could just reduce the 8 by 18 foster kids, get 18 foster kids out of the system and reunify them with their family, we could already potentially, break even in terms of the cost of the program, in terms of what our funding is. And so, while that's not, technically the cost effectiveness analysis that, we were talking about, it is a way to start kind of thinking about how do you start framing it and talking about that. And so that's just one example there about how we could do this. The other piece of information that, insight that this grantee shared with me was that the way they also look at it, and this kind of gets into the systemic pieces, is that they also look at it in terms of the human, what he called the human economy, that it's sort of this idea of the lifetime downstream costs of, when you have a child in foster care that has, the health issues, but also maybe the emotional, the mental health, the psychological perhaps issues, what are kind of the longer term downstream impacts of things like, academic achievement, career achievement, things like that later down the road. So, again, kind of bringing up the systemic piece. So, all right. And then in terms of, again, process and impact evaluation, again, I'm not going to go into a lot of detail. I think these measures are pretty self-explanatory. What I will point out, though, in terms of process, you've got the numbers engaged. But what I will point out that's a little bit different here from the others is that kind of speaks to some of the interim outcomes that, Paula mentioned with the cost effectiveness. And this is one way to maybe think about if you've got a program that's outcome is actually really focused on something that's not really healthcare related, how might you be able to talk, though, about a health-related outcome? And so this interim piece outcome is maybe one example, because what this program seeks to do is use a behavioral health intervention through counseling, through connection to community mental health, through access and connection to recovery coaches, which are like a peer-to-peer coach. It's through that intervention then, which is very much mired in behavioral health. It's very behavioral health focused. How then that's kind of the idea being that if you improve the substance use issues and the functioning of the parent, you're going to improve reunification. So with this, that's the interim outcome there is, looking at the percent of family exits. In other words, how many kids are actually going to be reunified. But also the other piece there that is the behavioral health is what they're doing is they are through their intervention, I mentioned the tools, kind of standard tools that are used. The substance use recovery matrix is a tool that Network 180, the service provider that Safe Passages works with, that's a tool that they look at and work at. So they have a goal of improving parents' functioning as measured by this substance use recovery matrix. And then, of course, the ultimate outcome is, as stated here, is really to increase family reunification. Okay. All right. So then, just kind of thinking about ways that, we could, sort of formulate this in terms of a cost effectiveness sort of statement or how you could think about it. And again, this isn't based on any analysis. It's more like how could you formulate this to, actually look at and think about cost effectiveness. And it kind of goes back to, again, that planning and being deliberate and thinking about your data and your audience and pieces like that. But again, so the interim, focused on the behavioral health could be the cost, the cost per parent. So what is the cost per parent to achieve 2 stages of improvement, which is the stated goal of the proposal of the project, on the substance use recovery matrix compared to other parents maybe not that are not in safe passages. And then the ultimate outcome would be focused on child reunification. And so what is the cost per child or per parent to achieve that reunification compared to those that are, remaining in the system or, what we call, quote, usual care. So that's another way of looking at that. And then again, looking at the, looking at lifetime costs. One of the pieces that was shared with me from this grantee was that what they have is research that shows $2,400 per parent savings over a 5-year period, and that's attributable to lots of different, lots of different areas, not just healthcare, but like reduction in foster care expenditures, residential treatment, emergency shelters. So again, looking at, kind of the broader view. So, okay. A couple minutes left. I'm going to probably skip over in the interest of time. Example 3, I can just kind of mention very quickly. So example 3, this one's a little more narrowly defined, maybe a little more straightforward. This is a what we call behavioral feeding program. It's a multidisciplinary program aimed at children who have a feeding tube for various medical reasons, and that they're not eating properly, and so it threatens their development and growth. So basically the basic equation. I'm not going to go through every slide, but the basic. Why don't we skip to the very end? The cost effective. Yeah. So essentially, and this is something that they looked at because this is a program that they used the funding to expand, but expand an existing program. When they started the program and wrote the grant, I think there was like a 20-month waiting list, 20-month-long wait to get a child in, and that's something like 390 kids on their waiting list to get in for this treatment. So they use this to expand access to this. But essentially what they were looking at is if we do this intensive behavioral therapy, which is very intensive because it literally practically involves the parent, it's a full-time gig, I guess, for lack of a better term, because it's 5 days a week for up to 8 weeks of the child and the parent being involved in this therapy, literally learning how to eat and get off of this tube feeding and avoid the tube feeding. Tube feeding being very expensive, very costly in terms of medical costs, but also in terms of the emotional, psychological opportunity costs involved there. And so this was essentially aimed at trying to use this therapy instead of the tube feeding. And so the way they phrased it is, in terms of per child to either avoid the tube feeding or discontinue. And they estimated, quite a bit of savings on that piece, and I'm happy to talk offline more about that. So I just want to wrap up about, some summary points about how to talk about. Thank you. How to sort of talk about cost effectiveness with stakeholders, and this might be, something that we can talk about a little more in the discussion and comments as well. But essentially, you want to keep it simple. You want to be clear. You want to really be able to express the bottom line. I think these are all things that we sort of talked about. You need to be able, again, building on what Paula said, talking about the value of the investment and the outcomes achieved rather than cost savings. Because I think there's a great deal of skepticism about that. And the other piece is that, understanding too that funding decisions can be based on a lot of factors. Sometimes you can do things absolutely right, you show the best outcomes, but because either the assessment of that effectiveness and value are somewhat subjective, or there's just other competing priorities, it's possible that it won't be funded or it won't, go anywhere. But I think, the key, and I'll just conclude here by sharing a comment from one of the grantees that I spoke with. and I'm just going to read their statement because I think it sums it up really well, is that the key is that reliable, easy to understand data is necessary to making the case for cost effectiveness. So, making it easy, making it reliable.
That's great. Thank you very much, Melissa, for those examples. That's enormously helpful, I think, to really put analysis in context with some of the programs you all are engaged in. I just want to ask you all, for those of you who have questions or comments or want to just provide feedback, to please type them into the chat box in the webinar, because we don't have the ability to take your questions verbally because there's about 50 of you on the phone, so we don't have a way to do it to have you all speak. So please type it into the chat box, and I will read them to the whole group so everybody can hear them and we can share the answers collectively. So we have several questions that have been typed in now that we'll start with. And they're all really great questions and some comments. So first of all, first question was, is it sufficient, and we can all, I think, take a crack at this answer, is it sufficient in most cases to identify that there are cost-saving elements without an in-depth evaluation to plan to explore these elements? So I'll be interested in everyone's comments on that, but I would start with, saying to the questioner, it really depends on why you're doing an evaluation and what your goal is, right? So who are your customers? Who are you trying to share impact with, and for what purpose? If your goal, as many of the examples that Melissa just outlined is to get ongoing funding for programs, then I would say the answer is no, that you have to go beyond just saying that there are cost-saving elements to showing at least some way of showing what some of that impact is. So, but let me ask Paula, Melissa, you want to comment?
This is Paula. I would urge you to be really, really cautious about that, because it is really hard to know if there are actually cost savings if you don't know what the impact of the intervention is. I'm actually in the process of doing a systematic literature review on studies that look at the impact of different kinds of interventions focused on super utilizer of healthcare populations, especially focusing on those super utilizers of emergency department services. And it turns out that just sort of showing that over time, this population, they had high use one year and then lower use the next year, that often happens even without an intervention, because people they have really bad years, they're high users, and just sort of naturally that use goes down the next year. If you lay an intervention on top of that, you don't really know how much went down because of the intervention, or just went down because people, again, these high users tend to just look better in the year after. So you're just going to want to be really cautious. As Marianne said, and this is not helpful to all of you, it depends. It depends on your intervention. It depends. I think a lot of you are probably implementing interventions where there actually are some evaluations in other settings, in other contexts, that you could look at and use to help make more substantiated claims about your own interventions if you're not doing full-fledged, rigorous evaluations. So I'd urge you to look at, other settings and contexts for that.
Yeah, great. This is Melissa, and I absolutely echo what Paula said about being cautious. I think it depends on what you mean by in-depth, because I think, where I see the importance is that you want to somehow be deliberate and thoughtful. And so I think it also goes to the end use of what you want to do with your, whether you call it evaluation or your program, or making the case for cost savings or cost effectiveness. I think, it's better to at least think about that on the front end and have an idea of where and how you're going to be able to make that case. I know that sometimes evaluation, can be it can be technical. It can be, a part of a budget that maybe you'd rather spend on, actually, doing the intervention and doing good. But I think, to the extent that you could look at other data, other evaluations and extrapolate and apply that, I think that's important. I think thinking proactively at the beginning of your program as much as possible, because what you don't want to do is get to the point where you're being asked to say, is your program cost effective, yes or no? And you can't really answer that well. Because I think, people, policymakers, funders, decision makers are getting to be more discerning consumers of that kind of information. So I think that, I think, and it does depend. I mean, it doesn't help, but, yeah.
Yeah, but I want to, reemphasize the point also that both Paul, and this is really for all of you, that both Paula and Melissa made. There has been a lot of research done and a lot of evaluation done, and in many cases, you are all building on work that has been done by others. That's how you got to the interventions you're really attempting. So don't underestimate the value of other research that has been done and published in the space that you're working in. And you can always pull that forward and talk about how your intervention fits, advances, builds on that work. And so there actually might be more other data that's out there, but do make sure you're gathering your own data about your own impact, right? So you need to start with that foundation of making sure you have data tracking mechanisms in place. I mean, we've all been involved too often in programs where after the fact we say, oh, we should have, when we started, kept account of how many referrals we made to these types of providers, or how many visits somebody had to, these kinds of services. So setting that tracking mechanism up at the outset is really quite important, and you can all do that. So I think building on the literature, setting up tracking mechanisms to begin with, so that you at least have the information to talk about impact is really, really important. Our next question, if we didn't answer the question, type in again. We'll be happy to do more on that. But our next question is a really important question, and one that I think many people struggle with all the time, and it really has to do with how you get access to the data that you need. So this question is specific. Our program goal is to decrease emergency service use by addressing social determinants of health, and we've had a hard time accessing claims data in order to show our interventions are cost effective. We get self-reported data from the clients, but any suggestions on other ways to show cost effectiveness? First of all, I think it's a great question because you're asking the exact right question. First of all, you know that you need claims data. That's a good start. And that is a very crucial piece to this particular type of intervention where you're trying to reduce the use of the emergency room by addressing social determinants of health, because I'm assuming your long-term sustainability plan is to convince health plans, Medicaid and others, to pay for these kinds of services. And so you do need to show them, that's your client, that you need to show them the impact that you're having. So there's a lot embedded in this question that I think is really important for doing this kind of impact analysis. Getting access to the data is a challenge. It helps. At the best, if you set up your intervention at the outset and you work with the owners of that data at the beginning to see if they will give you access, and you have to set up data use agreements with them, so talking to who are the health plans in your area, getting information from the clients is probably not a good way to get this kind of data because clients really don't know the cost of the services that they're receiving. They might know their own co-pays or their own deductibles, but they don't know the actual cost to the payer. So you want data from the payer. So if you could, at the outset or at any time, talk to the health plans in the area where you're serving and see if they will give you access to the data, or if they will help you become partners in analyzing the data themselves, because they should have an interest in this project working, right? So they might be willing to be partners with you. If you can't get the health plans, in this case, to give you the data, and then another better data source than clients are the providers of care. So partnering with the hospitals, to some degree the physicians are a little bit harder to work with because there's just so many of them, and they're not many of them will have a lot of volume, but certainly partnering with the hospitals would be a way to go to get the data. And then my last suggestion, then I'll turn it over to Paula and Melissa for additional thoughts, would be to talk to the state Medicaid office and see if they would partner with you, because clearly they're particularly interested in this kind of an issue as it affects the Medicaid population, and they may well be willing to help you get the kind of data you need. Paula, Melissa, you have comments on the general issue about access to data and how people can work through that?
The only thing, this is Melissa, the only thing I completely agree and concur with what Marianne said. The only thing I would sort of also add is when you're thinking about accessing claims data and, you know, whether it's through a payer or a health system or you know, the Medicaid data warehouse, you should be prepared to have some budget for that sometimes, because oftentimes what it will involve is working with a staff person at that, you know, at that place, and you know, money talks, I mean, for lack of a better way of putting it. So, you know, that's something to consider. It's not always the case, but in my experience, it's been more effective if you have some resources, budget to help compensate people for their time to do that work for you. Because it's not, you know, again, you have to understand that's not their immediate goal is to help you do an evaluation, no matter how much they want to do it. They've got, you know, 25 other things on their plate. So this helps them kind of prioritize and recognizes that they're putting in effort. So.
Yeah, and this is Paula. And whoever asked that question or anyone who's working on interventions in this space, I'm happy to talk to you otherwise. As I said, I'm doing work on this right now and doing a literature review, and I've seen a lot of different approaches to this. I mean, there are a lot of complicated issues. If you want access to people's healthcare utilization data, there are obviously issues related to HIPAA, and so you're going to have to get their consent. The people in your program getting your intervention, you would have to get their consent to get that data about them specifically. So that may be easier or harder for some of you depending on how you're interacting with these clients. But you have to keep that in mind. There are a number of studies that actually do both. They try to get self-reported data on healthcare use from clients, from people getting an intervention, and they also try to get it from the more administrative or claims data. And there's issues with both of them, but might suggest you actually try to do both. There's things you can get from clients about their perceptions, why they might have chosen, you know, different, you know, seeking social services rather than healthcare services, et cetera. There's a lot of information you can glean from your clients, and then also while you're collecting that information, get their permission to get access to their actual records. Yeah.
Yeah, and you know, worse comes to worse. You know, again, there's a lot of literature on the impact of interventions on social determinants of health, and some of that literature does have cost impact in some form in it. And you know, if you can't get access to actual data for your program in your community in Michigan, you know, use some of that data as a proxy and then show your impact in terms of the services you're providing, the number of people you're touching, and you just have to be clear in how you've got that analysis and what your assumptions are, right? And I guess that would be, but I don't, on this particular question, I don't want to underestimate the potential for partnerships with the hospitals, the health plans, the state, because they're all really interested in this question. And but it can be hard and it can take time. And that's the other thing, you know, that we didn't talk about, but that is also an issue with claims data, is there's often a lag in time between when people get services and when the data is available. So, you know, it is a harder path to go down, but it is quite important. But there are other ways to show your impact. Just make sure, and you know, I know we've said this several times, but I'm going to reemphasize it because I think it's important. just make sure you're keeping track of the actual services you're providing, what you can control, what you know about your own intervention, the cost of what you're delivering, the number of people you're touching, the kinds of services you're providing, so that at least you're gathering that baseline so that if you are using literature rather than your own actual impact evaluation, you can make comments about how effective and how related your intervention is to what others have reported on in the literature. So our goal here, as I said, was to give you sort of that foundational understanding of how evaluation is conducted, to give you some of the elements that evaluators use, to encourage you to be capturing data to show your impact. And you know, everyone, every foundation, every funder, every program is increasingly focused on this issue of impact. And we know that particularly when we're talking about healthcare, that we spend a tremendous amount in this country on healthcare costs. There's not always a view that we get good value for that spending. And so payers, whether it's the state or whether it's private sector, whether it's the federal government, are all focused on this issue of increasing value. And so that's, you know, kind of become a catchphrase right now, and they're all trying to measure value in some way. And they're, you know, some methods are better, as Paula said, better than others, but you know, she's really giving you that foundation of how people talk about value when they're talking about cost effectiveness, cost utility, or cost benefit analysis. So I'm going to ask Paula and Melissa to give you their last words of wisdom and advice as you go forward. Again, recognize we have a big range on this call of small grantees who are delivering community-based programs and don't have a lot of resources to do evaluation. And obviously, we have some people on the call who are very sophisticated in evaluation and really technical analyses, which is great. So, Paula, last word of advice for that range of grantees on the phone?
Oh, I basically want to thank you all for all the important, creative, and hard work you're doing to try to improve health in the state of Michigan, and just, you know, keep your eyes on the prize. That you have interventions that you really do believe will be providing benefit and value to people, and again, do your best to make the case for that value and benefit.
Okay. Thank you. Yeah, I mean, I would hope that you could walk away from today having some ideas of, you know, how you could talk about and think about evaluating, or, you know, demonstrating cost effectiveness. But I think, you know, just the importance of the planning and the thinking things through with your program. You guys are doing amazing work out there, and, you know, evaluation can be a really important tool. You know, and as Marianne said, it doesn't have to be in-depth, it doesn't have to be, you know, formal, but at least just tracking and thinking about ways to do that, so you can really, you know, help to communicate that. And I think that's really, you know, a really important piece. But, you know, again, I want to applaud all the, you know, hard work that you all are doing on behalf of, you know, people in Michigan. It's really great, and I'm really honored that you wanted to be part of this webinar.
Great, thank you, Melissa. So, Janet, we're actually going to unmute you. Maybe not. Can we unmute Janet without the background noise? She has to unmute her computer. Oh, you have to unmute your computer because we have some questions at the end about how to get in contact with us as facilitators. We are more than happy to provide additional information. I know that this particular webinar is being taped, and the slides will be made available by the Health Endowment Fund, so there's more detail on there. And so, and we can include our contact information as part of that, or it can go through Janet. Really, it's really the Health Endowment Fund's preference about how to get feedback, but we'd be more than happy to provide additional information. As Melissa said, our goal is for you all to be successful. We know that you're doing really great work, that you're serving such incredible needs in our state, and we want to help you be able to demonstrate that impact to those who help in your programs over time. So I think, Janet, I think you're unmuted. Do you want to say a word about it? Maybe not. Yeah, we're getting some background noise. So we'll just...
This is Janet. Can you hear me?
Yes, we can hear you. That's great.
Great. So I just want to thank you, Marianne, and I want to thank our presenters. As Paul indicated at the beginning of this webinar, this is our first ever Health Fund sponsored webinar, and we appreciate the Center for Health Research and Transformation carrying the load and helping us not only with content, but with the technical features of a webinar. And we appreciate that we've had so many attendees join us today. I think a couple of things. One is Marianne indicated we have been recording this webinar and we will be posting it on our website. We'll be sending you information about it. We will also be soliciting your feedback on this webinar and for our future planning in terms of conducting additional webinars. If you do have questions that you would like to ask of the folks in the Center for Health Research and Transformation, I think it would be great, Marianne, if you could provide folks some contact information, excuse me, and then I guess I would just ask that you copy us as well in your, in your questions to them, so we can see what questions you're asking as well. But that we very much appreciate your attendance, and we look forward to hearing more from you, our grantees, because we're all invested in your very important work.
That's great. Thank you, Janet. We will send we're going to be sending an evaluation questionnaire out to all the attendees and tomorrow, and we'll include our contact information in there for you to ask additional questions, and so you have some resources available for more in-depth discussion on some of these really insightful questions. So thank you all, and thank you to the Health Fund, to Janet for your leadership, and Paul for making this session available to the grantees.